it ticks all the boxes of the QIP agenda for the government and the ambulatory care. I mean, in April of this year, a best practice tariff was awarded. For some time now, there's been a NICE interventional procedure guidance. It's very well documented, and NICE have agreed that this particular type of surgery is very widely accepted as long as following audit process in place. So it's an old story, but it just hasn't got through to the masses. I think that's the challenge.
Sterilisation has always been popular, but obviously this can be male and female. But females always required a general anaesthetic, in contrast to male sterilisation, where that could be done as an outpatient. But one thing is to get men to go to the clinics, and now with the availability of sort of outpatient female sterilisation techniques, I think that paradigm has changed, and that female sterilisation is becoming more popular. But I think in general we have seen a decline in sterilisation, predominantly because of the development of good intrauterine hormonal devices, something called the Mirena device. But I think that now there's availability, as I say, of an outpatient permanent method of control for female sterilisation. I think we'll see some of that trend maybe, I wouldn't say completely reverse, but I think you'll see an uptake in demand, of female sterilisation methods.
So in a nutshell, the procedure is a simple application of two very tiny micro inserts. They're soft and flexible, and they're actually positioned via what's called a hysteroscope, which is actually a fixed device. It doesn't require any surgery, uses natural orifices of surgery, and in the outpatient form can actually be done under a local anaesthesia or no anaesthesia with very little application. For example, a non-steroidal anti-inflammatory and some paracetamol. It's less invasive for the body, of course. It's very simple and very effective and very quick. It's actually the most proven, effective, and well-documented long-term permanent contraception of its kind. It's the only kind now that's actually in the market. It works by the application of a tiny microinsert inserted into the UT junction, utotubral junction. That outer coil will anchor this implant in place, and inside of that is a polyethylene fibre, which will cause a natural response of the body to occlude that space over 3 months. There's a test after that 3-month period to confirm occlusion and placement, after which the patient can rely on this as a permanent contraception.
The bulk of these unwanted pregnancies happen between the ages 20 and 30, so we need to acknowledge that number-wise. These are the women who sort of come to services. But in relative terms, there is a higher proportion of unwanted pregnancies actually in the over 35s now. And it's the one statistic that is rising. Now, it's partly rising, I would think, because women are putting off their fertility to later on, but partly, I think, because there is a problem with access to information about contraception, about the choices that are available, and access to services.
I think there. If a woman's decided sterilization's for her, surely this has to be the number one choice. I mean, it's just a no-brainer, really. It's simple, quick, no risk of infection. But the big barrier is persuading women that sterilization's a good idea. And we heard how the figures have gone from 40,000 about 15 years ago to just under 10,000 a couple of years ago. So just under 10,000, that's hardly any women having sterilisation. That's a tiny market. I mean, of those 10,000, I'm sure most would choose this procedure. But the barrier is to persuade women that the finality of sterilisation is a good idea.
I'm not sure how many medics, let alone the general population, have been aware of Essure. And I think it's definitely a great addition to what's available in the range of contraceptive options. But as far as awareness, minimal until this evening, when my eyes were really opened.
You basically need to occlude the tube. It's a simple thing, really, that the egg comes down the tube and meets the sperm, and that's where fertilization takes place. So if you can prevent the passage of the egg down the tube and the sperm up the tube, occluding the tube, you'll provide effective permanent contraception. And traditionally, people have done this through a keyhole approach, making incisions on the abdomen to occlude the tube. But now, by going, as I say, through a natural passage, into the uterine cavity. One can get into the tube. And so what the technology, the Essure technology really is a little sort of wound down spring, if you like, about 4 centimetre or so, little wound down tiny spring, which within the middle of it contains a little fibre which encourages fibrosis, that's scarring within the tube. Yeah. And the reason it's this little spring device is actually what you do is you pass this into the tube, and then as you deploy it, it will spring open, and that's what holds it within the lumen of the tube. Yeah. But then it's the active ingredient, I say, is actually the substance, the dacron fibre within it. It's a tiny little fibre which encourages this scarring process. And over the course of 3 months, the actual tube will block. And the great thing about it is it's actually blocking the part of the tube, the part of the tube that's actually within the uterus. And that is the narrowest portion of the tube. So that's the most effective portion of the tube to block, really. So the advantage for women really are that, this is a very quick procedure. In most cases, doesn't require even passage of a vaginal speculum, which many women will be familiar with, which we use to visualize the cervix, say at cervical smears, and can be uncomfortable. So this involves really what we call a no-touch technique. A tiny telescope, we're talking sort of 0.5 centimetre in diameter, is passed through the cervix, that's the neck of the womb, into the uterus. The tubes are seen, the device is deployed in each tube. It takes around 3 to 4 minutes to complete the procedure, for a straightforward procedure. And, the patient you would expect to be home within sort of 15 minutes to half an hour. Some women do require a little bit longer, depending if some women are having a little, some more discomfort post-procedure, but the vast majority of women will be home within half an hour. So it really is a convenient office-based procedure.
If you're talking about different options for women, then obviously different things suit them at different stages of their reproductive lives. And I think this would seriously fill a gap, because without Essure, what you've got is a fairly invasive method of sterilization.
Technologies, for years actually, over the last century, people have recognized that you can access the female tube, through a natural orifice, transvaginally, without having to make artificial incisions in the abdomen, which current methods of sterilization require. And the difficulty has been actually finding an effective, not so much accessing the tube, but actually finding an effective method of occluding them, blocking them. And I think that only recently, over the last sort of 10, 15 years, has a technology become available, the Essure technology, allowing us to do this. Despite the fact it's been around for a decade, I think you're right. I think GPs aren't so aware of it. But having said that, even hospital doctors, it's not widely available in the UK. It has become increasingly the method of choice in the States and in parts of Europe. But for various reasons, it hasn't been uptaken so quickly in the UK. And this is to do with a degree of familiarity, but also to do with sort of funding and costs, as you alluded to earlier.
But just sitting here tonight, I realised in the last 3 years, or last 5 years, we've had several new options. Subcutaneous implants, Mirena, and of course Essure. I think Essure is the crowning glory, really, because for someone of my age, most of my patients are middle-aged and older, because in the world I inhabit, your practice cohort grows older with you. Yes. And I don't know if you've noticed that, but here, we have an option for the woman who's 40 years old, who's had trouble with coils before, who certainly doesn't want to take hormones, who may have a regular cycle and is obviously very concerned about an unwanted pregnancy. And this is just a perfect option, I think. And it was interesting, the young women in our meeting tonight were all talking about the difficulty of making a decision, and there was a problem about commitment to sterilization. I can imagine a lot of women, when I present this to them, will jump at it. Office procedure, no anesthetic, safe, relatively complication-free as far as I can gather. I think it looks like a very, very good option, and I think it will run and run. And people will say, how are we going to present this to people? But I think in time it will gain a momentum. I think it will be a slow burn, and it will gain a momentum, and it will find a place.
For a woman who was seriously considering sterilization, I would definitely recommend it. To a woman who was in middle age and has had a family, I would recommend sterilization as a whole. as a good option to consider. Yes, it has a finality about it, but let's try and be realistic. For most women, they might not want to think of shutting the door, but the door is already shut.
Really that quick, I was amazed. It takes sort of 3 to 4 minutes for the actual, once the hysteroscope is in, and then actually doing the procedure. Obviously there's a bit of time in the beginning positioning the woman and sort of doing all that sort of stuff, but it's very, very quick. It's an outpatient procedure. They were just holding the nurse's hand. It's not even like day case surgery. It's literally they're in there for the morning, which I think is I think that's a fantastic option for women. I think it's fantastic from the point of view of I think something you could do within the community. So it doesn't, obviously Justin's doing it in an outpatient setting, which is cheaper than a day case setting, but then even cheaper than that would be to be doing it in a community gynecology clinic or even in a GP surgery. But that's going to take a big sea change, isn't it, in our sort of contraceptive services.
Traditional methods of sterilisation are safe, but because it involves general anaesthesia and the potential risks of that, because it involves putting devices, making incisions into the abdominal cavity and entering the abdominal cavity, there are potential risks of injury to organs within the abdominal cavity, like the bowel, etc. And increasingly, as the population gets larger, as BMIs increase, as women having more caesarean sections, this makes that sort of procedure slightly more complex. And unfortunately, although it's a very safe procedure, many women do and have the complications as a result of that. Whereas with this procedure, the Essure procedure, the complications, because you're avoiding entry into the abdominal cavity, are really quite small.
The report from the All Parliamentary Group is out now. They've done a fabulous consultation process. The input was from the Family Planning Association, which is the voice of the consumers. They've actually taken case studies and case histories from women themselves, who essentially say, listen, I want to choose this for my fertility, but I'm not being allowed to. I go to a place and they wouldn't see me, or I go to a place to my doctor and he wouldn't refer me. So it's a very important report, and the report is recommending that in commissioning services, there should be no restriction on age. There should be no restriction on what we call postcode lottery, i.e. women who, for instance, will want to access community clinics in central London or central Birmingham or central Liverpool while they live in the south should be allowed to do that, because in a way that fits in with their lifestyle. And there should be no restriction on the choice of methods. This diktat that comes to GPs to say, when a woman presents for contraception, you tell her X, you tell her 2, you tell her 3, you tell her 4, but you don't tell her about 5, because we're not going to fund it, is really such a retrograde step in the way we deal with contraception. I mean, choice is a reproductive right which is enshrined in the United Nations Charter. So it's a very important issue. So I think the APPG report is a good starting point to really try to reverse this trend of restricting contraceptive choice for women.
I think, if you've come to the conclusion that sterilisation is an option you want to consider, why would you choose any other technique or option than Essure? Because it's simple, it's straightforward, it's quick, it's low risk. Why any other choice?
Are we giving women enough options? And actually, if there is this available, and we're only offering women sterilisation from the point of view of lapsteri, we're actually not doing our job properly, because they don't realise there's actually this sort of outpatient procedure as well that they could have. So I do understand that ethically speaking, you have to obviously let people be completely aware it's irreversible. It has to be sold as an irreversible procedure. But I do think we need to be offering women all the options. I know from my own practice, when women are looking for long-term contraception, sterilisation is something I really sort of gloss over, because I assume they won't be interested.